Hi, good evening. It is wonderful to talk on a different and very interesting topic, which is cardiopulmonary exercise testing. We are very proud to announce that very initially for the last few decades, very few centers were doing this regularly. But there are so many centers which are coming up, which are doing cardiopulmonary exercise testing, be it in medicine or in sports. A lot of interest and a lot of buzz has been shown. So today we are starting with the basics. So this is part one, which is basics. So all of you gear up for the next part, which is going to come up in January, which is in special situations. So I thank the Indian Chess Society, Dr. Rakesh Chawla and Dr. Amita Nine, who has given us this opportunity to do this, and the partners Schiller and Cipla, which has helped us in distributing the flyers and the disseminating of information. And on the speaker, we have Dr. Saurabh Mittal, and we have an excellent panel with representation from Northeast, West, and South, with people who are practicing cardiopulmonary exercise testing. So all of you can understand. So when the slides are being done, you will be able to understand a little bit on the basics. But as the discussion goes, we are dividing it specifically into ventilatory, cardiac, in exercise dysfunction, and other situations. So you will be able to identify and ask specific questions in each areas. So over to the speaker. I would like to introduce Dr. Saurabh Mittal. He is MD and DM Pulmonary and Critical Care and Sleep Medicine from, he is a current associate professor at AIIMS Delhi, and he's an assistant professor, and his areas of interest is sleep medicine, interventional pulmonology, TB, and pulmonary physiology. Saurabh has more than 200 publications, and we have listened to a lot of his talks on cardiopulmonary exercise testing, respiratory physiology. He's really good at it, and he does make it very, very simple so that it's easy for us all to understand. So over to you, Dr. Saurabh, for initiating the series. Thank you.
So good evening, everyone, and thank you, Dr. Supraja and Dr. Amita, for the kind invitation. So before we just start, I'll try to kind of sensitize our audience that obviously that CPET is a topic which is in general considered a little difficult, right? So what I have tried to do is that I have tried to make it simpler, and I hope that I am able to convey the correct message to the audience. So I'll not go into the very big details of the topic. I'll try to introduce, and then in the panel discussion, we can have a detailed discussion. Okay. So I'll start with the case. So our patient is a 57-year-old male who is a smoker and who has been diagnosed as COPD a couple of years back. His current PFT shows a FEV1 upon FVC of 0.52, that is an obstruction, and FEV1 is 33% of predicted, suggesting a severe obstruction. He is on treatment for COPD with a dual bronchodilator therapy, but the problem is he continues to have dyspnea. So when he was evaluated, it was thought that he may have a cardiac problem. His ECG was normal and his echocardiography was normal. But since he continues to have dyspnea, so a cardiopulmonary exercise testing was ordered. So I'll not go into the details of the report as of now, but I'll try to show you that how a test is done and what it shows. So this is the report of a CPET. So it has a lot of information which we'll discuss further, that it has the exercise timing, what was the indication of test, why the test was done, what are the patient's demographics. You can see this patient has a BMI of 19.2. Then it gives us some graphs which are done during the test, and then eventually we get a report of the test. So when I discuss these parameters during my talk, I'll come back to this report and tell you what are the parameters. But once you look at this report, a lot of you might have seen such reports in your practice. So there are kind of headings which are given here. First is the protocol of the test. Then there are some metabolic parameters, some ventilatory parameters, some cardiovascular parameters, and some gas exchange parameters. So all these things are measured and calculated during the test, and they help us reach a conclusive answer after the test. So this is the background which I thought it is important that everybody understands that what actually CPET is. So when we talk about CPET, the most common indication in our setting is evaluation of dyspnea. So when we have a patient as a pulmonologist who has dyspnea, we generally start our case with history taking an examination, and we do basic investigations. But what happens many times, we are not able to find a cause of the patient's problem after doing the basic investigations. And that happens because patients who complain of dyspnea on exertion, their physiology is different from the resting physiology. So if we do PFT, we are only looking at the resting physiology, but in CPET testing, we are looking at the exercise physiology and what are the responses of heart and lung during exercise, which leads to the patient having activity limitation. So in general, when we have no answer after our basic investigations, we reach out to CPET, that whether CPET can help us identify the cause of the patient's problem. So when we look at the common indications, the common indications are evaluation of exercise tolerance or undiagnosed exercise intolerance, patients who have cardiovascular disease or respiratory disease to look at their status. Sometimes for lung resection surgeries, you need to perform a pre-operative evaluation CPET so that you can look at the fitness and the post-operative complication rate. Sometimes CPET is done for the exercise evaluation and prescription before a pulmonary rehabilitation program is started. For evaluation of impairment or disability, and also specifically for transplant, specifically for heart transplant, CPET is a very good model to look at what is the risk of the and what is the high risk category. So these are the common indications of cardiopulmonary exercise testing. So now we talk about some of the contraindications, that means when not to do. So any cardiac comorbidity, any untreated comorbidity which can lead to problems during the test because patient has to exercise are considered absolute contraindications. There are some relative contraindications which we have to keep in mind while we are looking at the doing a CPET test in such patients. The one thing which the important which I want to tell you is that this test has around 2 to 5 per lakh exercise test performed may have a mortality. So in general, whenever we are conducting CPET, we generally take informed consent from the patient. When we see PFT, when we do DLCO, we generally don't take informed consent. But when we are performing a cardiopulmonary exercise test, we take an informed consent from the patient because this test may have some complications as well. So it is very important that the person who is doing the test or the clinicians who is attending the test or the doctor or the technician, they need to understand the physiology and then they should understand how to respond to an emergency during the test. Okay, so now we talk about how the test is done and what is the measure during the test. So in very briefly, what is required? We require an exercise equipment, which I will show you. We require some of the gas analyzers, ECG electrodes, blood pressure equipment, pulse oximeter and ABG machine if we are performing an arterial blood gas. So this is the basic equipment required for performing the test. So this is the setup of the test. So I'll just show that this is the machine which has a cycle ergometer. So there are two types of devices which can be used. One is the cycle ergometer, another can be a treadmill. So treadmill is seen behind the patient in the next image. Also, the last image shows the complete setup. So patient has a lot of ECG electrodes connected to them. Patient has a mask and a turbine here which helps identify the gas exchange. There are sampling lines attached to the face mask which gives us the oxygen intake and carbon dioxide output. The machine itself shows what is the work, what is the how much rate patient is working. So this is the basic setup of a cardiopulmonary exercise test. So I'm not going into the depth of this, that how it is done, but this is the basic setup how a CPET is generally performed and looks like when you are conducting the test on a cycle ergometer. Now, what are the phases during a test? It is also very important. So when we start the test, the patient is given to made to sit on a cycle or asked to walk on a treadmill. There is a rest phase. That means in the beginning, this patient has to just sit there and not to do anything. Then patient is asked to a cycling which is not loaded. So there is no resistance to the cycle. Patient just cycle very freely. Then gradually the load to the cycling is increased. So that means patient has to cycle, but the resistance continue to increase. That's called a loaded phase. And once patient reaches the peak exercise, then we put in the recovery phase and patient starts recovering from the exercise. So this is a very basic how the test is actually performed and how the test is generally looks like while it is being done in a physiology lab. Now we come to the core of my talk, that what are the measurements which are done during the cardiopulmonary exercise testing, and these are the values which we see on a report when we get a report. So and how do we read these? So their measurements are given on the external work. That means how much watt was given to the patient cycle gradually. So there are various protocols which can be used to increase this work rate during the exercise. Then the device measures metabolic gas exchange like VO2, VCO2. We will see what these are. Some cardiovascular parameters, some ventilatory parameters, some gas exchange parameters. If you are doing an ABG, then you have certain parameters which are coming from ABG. And of course, we have to monitor the patient's symptom during the test so that we do not let the patient have complications. So this is what is measured during the cardiopulmonary exercise testing. So we'll go to these parameters one by one and see what they actually are. The first parameter I'm going to talk about is the VO2. So VO2 is the oxygen uptake. That means the amount of oxygen which is consumed per minute. This is the key parameter and it is the best index of aerobic capacity of a person. So it is considered gold standard for fitness. The resting value of VO2 is 3.5 ml per minute per kg, and as the patient exercises, it generally can increase up to 50 ml per minute per kg. So this is the most important parameter which comes out of a CPET, which we all have to understand is the key parameter. This is the oxygen uptake per minute. So it depends upon a lot of parameters such as the blood hemoglobin saturation, what are the temperature, and what is the muscle function, what is the mitochondrial function. So VO2 max is the key parameter which gives us what is the cardiorespiratory fitness on of the individual. So just remember that VO2 is the most important parameter during a CPET testing. So when we look at the report, so this is the parameter, the VO2, which is seen here. So VO2, we have some predicted values and we can have certain values which are measured. So you can see the red value 1116, that is the measured value of our patient. Now the second value is the VCO2. So when we have VO2 is oxygen uptake, then VCO2 is carbon dioxide output per minute. Okay, so amount of CO2 which is produced per minute. So this graph which is shown on the screen is something very important. So if you see on x-axis we have VO2 and on y-axis we have VCO2. So as a patient starts exercising, the VO2 increases and VCO2 increases. So both increase. That means oxygen consumption increases and carbon dioxide output increases during the patient's exercise. But at a point, there comes a point when CO2 output is much more than the VO2. This is the point which is called as the anaerobic threshold. That means at this point of time, aerobic exercise has become the anaerobic exercise. So this you have to remember, when CO2 production exceeds the oxygen consumption is the point when anaerobic threshold actually reaches. So this is another point which I will going to discuss, that this is the anaerobic threshold. Now the ratio of these two values, like in physiology we read about the respiratory quotient. Okay, so there it is called, here it is called as respiratory exchange ratio or RER, or sometimes it is referred as RQ also. So ratio of VCO2 by VO2 is RQ. So normal value at rest is around 0.7, but as exercise increases, you can see in this report that patient's value has gone maximum as 1.29. That means patient's CO2 output has exceeded the oxygen consumption. That means patient has actually done a good test from his maximum capacity. So respiratory quotient or respiratory exchange ratio is a measure by which we can measure whether patient has actually done the test properly. The next value which I discussed previously as well is the anaerobic threshold. So anaerobic threshold is the time when oxygen consumption, carbon dioxide output exceeds the oxygen consumption. So the second line which is written here is that it is expressed as the percentage of predicted VO2 max. This is important to understand. Supposedly a person who has a VO2 max of 2000 and he reaches a anaerobic threshold at 500, then it is said that anaerobic threshold is 25%. Okay, so in general, it is considered 50 to 60% is normal. So on the report, you can see the value that here it is given 960 for this individuals. So this has to be divided by the predicted VO2 max to get the calculate what is the percentage of anaerobic threshold. So anaerobic threshold I discussed can be measured on multiple times. So the easiest one is that where the VO2 VCO2 actually exceeds the VO2, but there are other measures as well, like for the ventilator equivalents, which I will discuss in next slides. Now, this was the ventilator thing. Now we talk about the cardiac responses during exercise. When patients starts exercising, their stroke volume and heart rate both increase. But when patient has a very high level of exercise, only heart rate continue to increase. So this is important to understand when we look at the heart rate response during exercise, that we will see a kind of a very sharp curve which is going heart rate. So for heart rate calculation, so there is something called as the predicted heart rate. Predicted heart rate is 210 minus age. Supposedly an individual who is 30 years of age is conducting a CPAT, then his predicted heart rate would become 180. But if individual is more than 40 years of age, like our patient was 50 years of age, then you have to multiply it by 0.65, and then you have to reduce that value from 210 to get the predicted heart rate. What we want during test, that patient should reach as near as the predicted heart rate. That means if patient's heart rate during the exercise reaches his predicted heart rate, that means patient has actually done a very good test and has put his maximum effort. So the difference which remains there, that means predicted heart rate and the actually achieved maximum heart rate, that difference is called as heart rate reserve. So this heart rate reserve is also a very important value during the CPET interpretation, that we have to see what is heart rate reserve. Okay, so I am trying to tell you the basic words which come during the report and what do they mean. Now the next value which I am talking about is the oxygen pulse. So we talked about VO2. VO2 was oxygen consumption per minute. So once that VO2 is divided by heart rate, it becomes oxygen consumption per heartbeat. Okay, so this value is given name as oxygen pulse. So oxygen pulse is a parameter which is calculated during CPAT, and a low oxygen pulse generally reflect a deconditioning, a cardiovascular disease, or sometimes maybe in the ventilatory restrictions. So oxygen pulse is an important parameter for specifically for the cardiovascular fitness. So oxygen pulse is given in the machine in the report. So the last value on this report, you can see that VO2 by HR in this patient is 9, which is low. So you can also see the heart rate, which is maximum is 179 for this patient. That is 93% of predicted. Heart rate reserve is given as 13. So generally a heart rate reserve of up to 15 is considered normal. But if heart rate reserve is more than 15, then we say the patient has not exceeded or reached the maximal capacity. Now, blood pressure responses are also important during the test, but I'll try to skip this slide. So now we talk about the lung ventilation. So whenever a patient starts to exercise, what happens? Their tidal volume as well as respiratory rate continue to rise. Okay, so when they are at lower level of exercise, their tidal volume increases, but when they reach a very high level of exercise, then only the respiratory rate increases. This is important exercise response, that initially tidal volume increases, but at the end of it, only respiratory rate increases. So the machine will give us what is the tidal volume at peak, what is the respiratory rate at peak. Now, another concept is ventilatory reserve. So as a pulmonologist, we all understand what is minute ventilation. Minute ventilation is tidal volume into heart rate. So when we talk about this minute ventilation during exercise, initially minute ventilation increases because of the increase in tidal volume, but as the exercise increases, because of respiratory rate, minute ventilation continue to increase. So during exercise, the VE is represented on the screen by the minute ventilation. We see the rest minute ventilation was 13.2 and maximum minute ventilation was 55.4. So that means during exercise, minute ventilation continues to increase. That means lungs continue to increase their function and ventilation is increased. Now what happens when you reach a maximum minute ventilation? That means whatever you achieved during the test is called VE. Okay, now what is this VE? VE is what your lungs reached maximum during the exercise. Now we talk about another concept which is called as the MEMVV, maximum voluntary ventilation. Okay, maximum voluntary ventilation is what maximum a person can achieve in terms of ventilation. So MVV is generally calculated by 40 into FEV1. Okay, somebody who has a FEV1 of 2 liter, their maximum voluntary ventilation would be somewhere around 80 liters. So like this person, the patient which we are talking about, if he has a ventilatory reserve, maximum voluntary ventilation of 80 liters, but his VE is 55, that means that gap between the two, what he can maximum achieve and what he achieved during the test, the gap between these two is called as ventilatory reserve or breathing reserve. I think this is one of the most important concept for the pulmonologist to understand in CPAT, that what maximum can be achieved is MVV, but what patient maximum achieved during the test is called minute ventilation, and the gap between the two is called as the ventilatory reserve. Okay, so that ventilatory reserve has to be at least 15%. That means if somebody who reaches a very high level of ventilation during the test, that means their lungs are not good. When ventilatory reserve is very poor at the end of test, we think that it is the ventilator, and that means lungs are at the problem causing dyspnea. I think this is the easiest and most important concept of ventilatory reserve, which leads to exercise limitation during the CPET. Now we talk about the next concept, which is the ventilatory equivalence for oxygen and CO2. So VE is minute ventilation. So we have two values here, VE by VO2 and VE by VCO2. That means minute ventilation divided by oxygen consumption and minute ventilation divided by the CO2 output. These are called as the ventilatory equivalents. So this graph, which is shown on the center of the screen, shows that as the VO2 increases, these equivalents tend to go down initially, because minute ventilation does not increase proportional to the oxygen or CO2 use. But at a point, what happens, that they tend to increase. That means minute ventilation disproportionately rises. And that's where the anaerobiasis started. So I'll not go into too much of detail of this concept, but you need to understand there are two things which are called as ventilatory equivalents, and they tell us the gas exchange. Specifically, the VE by VCO2 value tells us how the gas exchange properties of the respiratory system or the cardiovascular system is there. So VE by VCO2 is something which is very important value to interpret an exercise test. Now, another thing is here is that the black dots show a ventilatory equivalent for oxygen, and the white dot shows the for carbon dioxide. If you see, the VE by VO2 is lowest earlier as compared to the VE by VCO2. That means VE by VO2 reaches a lowest value earlier than VE by VCO2. This is also very important. So if they are apart, then it is normal. But if they both reach the lowest value together, that generally happens in patients who have anxiety or psychogenic dyspnea. So if VE by VO2 and VE by VCO2 reach a nadir value together, that suggests an anxiety or a psychogenic dyspnea. So that's another important concept to understand the exercise limitation during CPET. So this kind of slide shows the report gives us the VE by VO2 and VE by VCO2. Like in this patient, we can see that their VE by VCO2 is slightly elevated, not too much elevated. Now we also monitor patients for symptom during the test. So when do we stop the test? So when patients have too many symptoms. So in general, modified Borg scale or visual analog scale is used during the test. So patient is asked to continue exercise as much as he can. But if patient dyspnea level reaches a very significant level where he cannot exercise more, we have to stop the test. So all the time the test has to be generally symptom limited. So when we have talked about the basic parameters which are measured, we'll talk about what is the normal value. Okay, so like in PFT, we have normal as more than 80% of predicted. Okay, or we have a Z score which is more than minus 1.64. So for CPET also we have something called as normal value. So VO2 max, which is the key parameter, generally more than 84% is called as normal. Anaerobic threshold, as I discussed, considered normal is 40 to 60%. heart rate, that means the peak heart rate during the test should be more than 90% of predicted, and heart rate reserve should be less than 15 beats per minute. A blood pressure response of very high is not considered normal. Oxygen pulse is VO2 by heart rate. So that should also reach more than 80% of predicted. Ventilatory reserve, that means gap between minute ventilation and maximum voluntary ventilation should be more than 15%. Respiratory rate should not exceed 60, and there are some oxygenation parameters as well. So these values are not absolute and they would vary from population to population, but these are the generally considered values which are generally used for interpretation of the test. Now, when do we stop the test? So this is also very important for technicians to understand that if patient complains of chest pain which says ischemia, or when we are monitoring the ECG, if there is an ischemic change or any arrhythmia happening on ECG, if there is fall in blood pressure or a very high blood pressure, desaturation, or patient has symptoms, then you have to stop the test because you do not want patient to collapse during the test. So this is very important thing that the technician or the doctor who is attending the test need to understand. Then when do they stop the test prematurely? Otherwise, the test should always be stopped when patient says that I cannot exercise more. So test should always be symptom limited, but in these situations, test can be prematurely terminated. Okay, so that's what I was talking about, what the test is all about and how it is done and what all we measure during the test. I'll have just one or two slides on interpretation because I think that's key for the audience or the pulmonologist. So when we talk about interpretation of the CPET, first of all, we need to see why the CPET was done, what is the patient's background disease, whether that disease is treated or not treated. Then we look at that how the test was performed, whether patient has actually performed the test appropriately or the test is prematurely stopped. Then we look at certain key variables and I'll tell you what are the key variables. And then after looking at those data which I showed you in the beginning, the table and the graphs, then we reach a conclusion that how the CPET has to be interpreted and what is the likely cause of the patient's problem. So the key parameters which I have taught you during this discussion and very important for remembering is VO2 max, heart rate maximum achieved and heart rate reserve, maximum minute ventilation and the ventilatory reserve. That means the gap between the MVV and the maximum minute ventilation. And then we look at the saturation, oxygen pulse or ventilatory equivalent for CO2 for certain things. So I think I'll skip these slides, and what is this patient has probably we'll know at the end of our discussion that how do we actually interpret the result. So just to conclude, so we need to understand that CPET is required in general practice for diagnosis of unexplained dyspnea most commonly, but a lot of times it will be required for pre-operatively, for exercise prescription and other indications, or for transplant. And as a pulmonologist, we need to understand the basic exercise physiology while we are doing the test and while we are interpreting the test, because otherwise we will not be able to do the test properly and interpret it properly. And the equipment which is to be there has to be calibrated in general, because if you do not have equipment which is calibrated, you will have wrong values and you will not be able to interpret the test result. And the last and the most important point is that the report has to be always interpreted in a correct clinical setting. That means what was the indication, what does patient has, because similar looking reports may come from different kinds of patients. So you should know why this test was done, what is the patient status, and then only you should do the test and interpret it accordingly. So that's all from my side. Thank you. Praja, you are muted, I think.
Yeah. Thank you, Saurabh, for the wonderful presentation. We will move on to the panel discussion because we have wonderful speakers in our panel. And Sipla, can you share the slides, please? To begin with, we have Dr. Nitin Abhyankar. He needs no introduction. The whole country knows him. And he is currently the HOD Pulmonary Medicine at Pune Hospital and Research Center. And sir was he conducted NAPCON in 2022. Next, we have Dr. Balamugesh from CMC Vellore. He is currently the professor and head of Unit 1. and he is Associate Medical Superintendent of in the Medical Services Division, and he is in the Ranipet campus. And he's ex-locum consultant at Lancashire Teaching Hospitals, Preston, between 2018 to 2020. Achievements: he has received the Dr. KJR Murthy Oration Award for the year 2020 NAPCON, and he has received the ICMR Award in recognition for significant contributions for biomedical research, the Srimati Kamal Sadbir Award for the year 2006. His areas of interest is lung cancer, advanced bronchoscopy, cardiopulmonary exercise testing. And sir does a lot of work in CPET for many, I think almost for 2 decades they've been doing that, and he's extremely well versed with that. Next, we have Dr. Arup Halder. He is from Kolkata. He is both a pediatrician and a respiratory medicine specialist, and he is currently a consultant pulmonologist at Calcutta Medical Research Institute. And his membership is in ICS, ERS, WSS, and AASSM. He has also had fellowship in epidemiology and biostatistics. He has more than 100 conference presentations, more than 30 publications, and 4 book chapters. And he was awarded the Doctor of the Year, Columbia Asia Hospital 2011. His areas of interest is in sleep medicine, physiology of the lungs, critical care, air pollution, and related diseases. And others, he's a content writer in World Sleep Academy by the World Sleep Society. And he's a regular blogger at arupsblog.wordpress.com. And he has more than 24,000 readers across the globe. And we also have Dr. Sachin Kumar from, he's an MD, General Medicine, and DM Pulmonary Critical Care from PGI Chandigarh. He's an interventional pulmonologist, and he has been trained at Lausanne, Copenhagen, Amsterdam, and Italy. He has more than 40 publications in international peer-reviewed journals. His interest is in asthma, ILD, interventional pulmonology, and sleep. And he has been conferred the FCCP and European Diploma in Respiratory Medicine for his expertise and achievement in this field of work. So we have an excellent list of panel.
And Supraja, let me have the honor of introducing you. She's MBBS DNB. She is someone who is managing trustee at LVO 4D Trust. She is the lead consultant and director at the Medway Institute of Pulmonology in Chennai. Her interests are pulmonary rehabilitation and predictive medicine. And she has a lot of research work in genetics in patients with respiratory diseases, lung organoids for future lung transplantation, and sleep medicine devices. Some of these topics I haven't even heard of. So I think that you're working in somewhere into a different zone altogether. She's been awarded with the oral presentation on VAP in cardiac surgery in Seoul 2022, ERS Young Investigator Award in 2009 in Hanoi, SN Gaur Young Scientist Award in 2018 NAPCON, and PS Shankar Award for Innovative Research in 2016 NAPCON. With that, I need to hand it over to you back to Supraja. Thank you.
Yeah, thank you, sir. So to the audience, see, all of us look at numbers, graphs on a daily basis. We have been tuned to it from the beginning of the first year of post-graduation. So CPET is no different. It is, you have to understand that you're going to do it a dynamic pulmonary function test while you are doing some exercise, and also you're combining with a treadmill. So we are well equipped. We are very great at looking at numbers. So we shouldn't be running away from numbers. And differently, all these graphs have both X and Y, and on the left and right, both the parameters are going to be there. That is because so much of data is generated in the few minutes that the patient is going to exercise. So as we have divided, it is going to be in ventilatory, or it can be cardiac, or it can be pulmonary vasculature, or it can be gas exchange, or it can be a non-cardiopulmonary cause of breathlessness. So we will go through a series of questions initially until I get questions from the chat box. So we will start with Dr. Nitin. So we have divided the topics into these as I have suggested, and Dr. Nitin will take topics on the ventilatory parameters. Sir, to refresh to the people who have just joined in. So what are the parameters that we look into a ventilatory if you are looking at a CPET report?
I think if you are looking at CPET report, the first order of business, the easiest sort thing is look whether the person has acquired at the end of the test a normal peak oxygen uptake that is in excess of 85% if he has done that, and or a peak workload of more than 80%. That means the person has a normal oxygen uptake or a peak workload. This is essentially a normal exercise performance, and therefore you need not really look into the rest of the report at all. I mean, he is normal for all practical purposes. Just these two parameters are enough. Of course, it's not as simple as that, because you are going to need a lot of other parameters. So then you start assessing the effort, and uh, uh, in fact, if you look at look at the report, and the patient who has not achieved normal peak oxygen uptake or a workload, then we start looking for the maximal volitional effort. The maximal volitional effort is demonstrated by a high respiratory exchange ratio, RER, which is indicating a significant anaerobic metabolism. RER, respiratory exchange ratio, as the speaker has already told us, it is zero point 0.8 at rest, close to 1 at anaerobic threshold, and something which is in excess of 1.16 or in 1.20 will be considered to be a acceptable effort when we are doing a maximum test. In addition to that, the heart rate also should be 100, more than 90% of the predicted. So these are the two parameters which we are looking at. If I have a person who has done sub-maximal, below this, I'm not 100% sure whether I'm going to interpret these in the sense that I should be doing it or not. The patient who has put on a maximal effort but has not achieved a normal peak oxygen uptake, the next step is to assess whether there is a normal ventilatory response to exercise. And of course, then in the ventilatory setting, I mean the ventilatory parameter setting, you look at what is the breathing reserve. A low breathing reserve, typically maximum voluntary ventilation, MVV, minus the maximum ventilation that he achieved at the peak of the exercise, should be less than 30%. I mean, he talked about 15%. I would say 15 to 30%. So that would be the range in which you will go. And that suggests that the exercise may be limited. If it is less than 30%, then it should suggest that the exercise may be limited by ventilation, which is essentially abnormal. So, in fact, that's how you start doing your maths.
Yeah. So like in spirometry, we generally say FEV1, that's the number we look into. But then, of course, there is so much than what meets the eye. So how the graph is, how the performance and other things. So the first value is going to be your VO2 max that you're going to look into. Okay. In the same context with key CPET findings, Dr. Balamugesh, what do you think is the cardiac parameters that anybody should be looking into for exercise intolerance?
So I would like to enumerate the cardiac parameters. They are 8 in number. The first and foremost is what Dr. Nitin has already said, the maximal oxygen uptake. So in cardiac causing the exercise limitation, of course, the maximum oxygen uptake also will be reduced. Then we look at the anaerobic threshold, number 2. There will be early onset of anaerobic metabolism in such patients because the cardiac output is unable to meet the metabolic demands, increased metabolic demands during exercise. So there is early onset of anaerobic metabolism, early lactic acidosis, so that shifts the anaerobic threshold earlier to typically less than 40% of predicted. There will be, then we look at the oxygen pulse. Oxygen pulse, as Dr. Saurabh told, it is the oxygen uptake per cardiac cycle, per heart rate. And there will be flattening or failure to, or yes, decline in the oxygen pulse during peak exercise. So that is the third parameter. The fourth parameter which we look in cardiac limitation is abnormal heart rate response. In some patients, there will be a chronotropic incompetence with exercise. So as we heard, during exercise, the heart rate continued to increase, but in some individuals, the failure to increase heart rate suggests that there is some abnormality. The next one is people with cardiac dysfunction usually has perfusion defects, inadequate lung perfusion, as well as there is pulmonary congestion. So these will cause ventilation perfusion mismatch, and they will increase ventilatory equivalence as well. Then we look at the ECG changes. Are there ischemic changes? Are there arrhythmic changes with exercise? And finally, the breathing patterns. In those with severe cardiac dysfunction, you may find oscillatory breathing during exercise. It is similar to the Kussmaul breathing, Cheyne-Stokes breathing, which occurs at rest in advanced cardiac failure. Such a phenomenon can occur during peak exercise also in those with cardiac dysfunction, and this is due to increased circulatory time between the heart as well as the chemoreceptors. So these are the various parameters by which we can suggest that this patient has cardiac limitation to exercise.
Wonderful, sir. So we all are now we know that lungs, the oxygen is taken in by the lungs. So there is a lung as an apparatus. Then it is being circulated by the heart, which is the second apparatus. And the third apparatus is going to be the peripheral muscle. So between the heart and the lungs and the peripheral muscle is going to be the pulmonary vascular, which is going to help in conducting oxygen. So Dr. Arup, so what are the CPET markers which are suggestive of a pulmonary vascular disease?
So this is very interesting, actually. A CPET marker for pulmonary vascular disease are actually a combination of the ventilatory limitation and the cardiac limitations, mainly. So you have a group 1 pH. There we'll have first a gas exchange abnormality. Or if it is a group 3 pH, you will get a ventilatory limitation and the gas exchange abnormality and a cardiac limitation. The main parameters which are abnormal in pulmonary vascular disease is the VE by VCO2. So the VE by VCO2 gives you the number which gives you idea about ventilatory inhomogeneity or ventilatory inefficiency. So in pulmonary vascular disease, we have a very high VE by VCO2 ratio. Okay, so if the VE by VCO2 ratio is more than 60 in your CPET test, then you should strongly suspect whether this patient have a pulmonary vascular disease or not. Second thing which you see is the low PET CO2. So PET CO2 is measured in the mouth. So this is the amount of carbon dioxide which is eliminated. This is also low because of the high VDVT. That means high dead space ventilation we have in pulmonary vascular disease. So what happens in pulmonary vascular disease? You cannot augment your cardiac output because of the right ventricular limitations. So the newly recruited portion of the lung, especially in the upper portion of the lung, which is ventilated, does not get sufficient amount of perfusion. So your ventilatory inefficiency or the dead space ventilation is very high in pulmonary vascular disease. Apart from that, you get a marker of cardiac limitations. That means you also have a low anaerobic threshold less than 40%. You have a low O2 pulse. That means the stroke volume cannot increase further. You have an early plateauing of the O2 pulse. And you also get a ventilatory limitation where your ventilatory reserve or breathing reserves come to less than 30% or within 15 liters to 11 liters, which is never normal for a normal person. So one thing I would just like to add here, we are always limited. A normal person is always limited in exercise by his cardiac limitation, never by a ventilatory limitation. So in any person, if you get a ventilatory limitation, that person definitely have a ventilatory problem, or it may be a gas exchange problem because of the pulmonary vascular disease.
Okay, beautifully explained. And in the similar context, there's been a question by Dr. Mehak from Maharashtra, Mumbai. So what is the importance of V by VCO2? So I think Dr. Arup has told that in a nutshell. And Dr. Arup, can you also take one more question? Which
Right.
condition gives the highest V by VCO2 slope? Is it
So,
COPD or is it LD or PAH?
So VCO2 slope is not specific for any of the disorder we measure in CPET. It may be high in pulmonary vascular disease. It may be high in ventilator limitation. It may be high in cardiac limitation. So apart from the VCO2, you have to see the other parameters, like if it is associated with low O2 pulse, early anaerobic threshold. This is a cardiac limitation. If it assesses the high VCO2 associated with the achievement of the breathing reserve, then it's a ventilator limitation. So you have to judge the other parameters, and the VCO2 should be interpreted in light of that. But very high VCO2 always gives you a clue that this patient may have a pulmonary vascular disease.
Okay, wonderful. Dr. Sachin, so in context with gas exchange, what do you think will be the parameters that you will be looking into?
See, gas exchange, primarily there are two gases which we are dealing with, oxygen and carbon dioxide. So the parameters on CPET is mostly how inefficiently, means the body is working hard to wash out carbon dioxide, and at the same time it is trying to manage your oxygenation under stress. So there are four parameters generally which we see in CPET for gas exchange. One of them, as earlier Dr. Arup has told, V upon VCO2 slope. For the benefit of others, if we correlate with the graphs, we have 9 graphs. So the 6, 8, 9 to an extent are for gas exchange, and 1, 4, 7 most of the time like ventilatory. To make it simple, but correlation is that plot number 4, so that we can correlate with a real report also. Plot number 4 will have V upon VCO2, and the slope, as Dr. Arup told, normally what it means is how much air you are breathing out to flush out 1 liter of carbon dioxide. So that is V upon VCO2. Normally it should be less than 35. So if it is more than that, it is abnormal, and it signifies wasted ventilation. Means patient has to breathe more to wash out a particular level of carbon dioxide, and generally the causes would be pulmonary hypertension, heart failure, or even in ILDs. And to touch upon, normally literature says if it is very high in the sense more than 45, 50, 60, then generally CTPH or pulmonary hypertension is the culprit with the combination of low and tidal carbon dioxide. So that combination generally points to that thing. That is the first parameter. Second parameter is generally EtCO2, which is a counterpart of end-tidal carbon dioxide, which normally means that you are hyperventilating. As the workload is high, heart rate is high, the body has to wash out more carbon dioxide. Normally, normal response is 3 to 5 millimeter, it should increase. But if you are having a decreasing EtCO2, which is seen in panel number 9, so generally if you have it wash out, that means you are hyperventilating. It can again happen in pulmonary vascular disease as well as ILDs. And third parameter, which is very important, is increase in alveolar arterial gradient. Now this will require an ABG to be done apart from normal CPET, because see, it's a normal physiology. As we exercise, the gradient will increase, but 20 to 30 is the normal cutoff. But in certain scenarios, if you keep on exercising, the body is not able to cope up the oxygen supply. So there would be a widening of this gradient more than 35, and generally it limits. The main common physiological counterpart is diffusion abnormalities and also VQ mismatch. And also one important thing about increased alveolar arterial gradient, that it fixes the lung, the responsibility on the lung side, whether it is parenchyma or vasculature rather than heart. So increase in arterial alveolar gradient takes the onus on the lung part. That is very important. Finally, oxygen desaturation, again panel 9. So this is the fourth parameter of interest from my side, that a normal person on CPET, if he's desaturating, then generally there could be a diffusion limitation like ILDs or emphysema, or it could be basically because of shunt physiology. So sometimes like right to left shunt or AVMs will desaturate because, and the definition of exercise induced desaturation is basically 4%, more than 4%, or 88% in absolute value. So if we have these 4 parameters, then we have a significant gas abnormality, and obviously we'll touch upon this as the discussion goes on.
Yes. So to the audience, the point why we brought in the key parameters is there are so many parameters. Now, why initially we started CPET is you have done a PFT, you have done a echo, you have still not identified what is the cause of exercise intolerance. That is why. So there will be so many differentials and so many plots which will be able to help us to identify. So Dr. Saurabh, I'll be asking a direct question and a couple of questions from the audience. So in non-cardiogenic cardiopulmonary limitations, so what are all the topics that can come into, and what are the findings in CPET, which are the plots or parameters that you can be looking into?
Okay, so first I would like to tell everyone that I have actually not shown the plots of the CPET to keep the talk very basic. So there are generally 9 plots which are plotted during the test, but I think that's a little next step for everybody to understand. So I have not discussed about the plots. So it's a very basic thing which I have talked about. Now, secondly, when we talk about the exercise limitation, the two things which come in mind are the pulmonary and cardiac. But there are other problems such as obesity, deconditioning, muscle dysfunction, or maybe psychogenic or dysfunctional breathing. So they can also lead to exercise limitation in these patients. So when we talk about each of these, so if supposedly if we have a patient who's obese and otherwise he's okay and he has exercise limitation, so his CPET would show us that probably his VO2 is normal, but VO2 per kg is actually low because of the high weight. But if we calculate it for the ideal body weight, then his VO2 per kg will also be normal. So obesity will lead to a non-specific decrease in the VO2 per kg. Okay, that is the only problem we generally face in patients who have obesity related exercise limitation. Now, next we talk about the dysfunctional breathing, or what we used to call as psychogenic dyspnea. So there are few parameters which can help. The best parameter for identifying a psychogenic dyspnea or dysfunctional breathing is the erratic pattern on the minute ventilation. So when you have a patient who is very anxious or has dysfunctional breathing during the test, so if you look at the graph of the minute ventilation, there will be very erratic reading. That means it will increase very high, then will go down. So that tells me that patient's breathing during the test is very unstable. So once you see the pattern of unstable breathing during the test, that's when you diagnose that likely cause of dyspnea is dysfunctional breathing, and provided that you have actually excluded a significant cardiac and pulmonary limitation. Okay. Now, when we talk about the deconditioning, deconditioning will also lead to, that means you find that there is no ventilator limitation, no cardiac limitation as taught by others, and you have reduction in VO2 and you have a reduction in the anaerobic threshold, mild reduction, that would generally happen on patients who have deconditioning. And if we talk about the muscle dysfunction or muscle disease, these patients will have a slight decrease in VO2, but they will have a very high decrease in AT. That means their anaerobic threshold would actually start very early because their muscles are not working properly and they tend to produce the lactate very early. So their anaerobic threshold will be somewhere around 10%, 15%, 20%. So if you see this kind of anaerobic threshold, that means your peripheral muscles are not working well and you are likely to have a myopathic pattern or a peripheral muscle dysfunction. So these are very easy parameters which I have tried to tell, that these obesity, dysfunctional breathing, deconditioning, and peripheral muscle dysfunction can be seen from a CPET report.
Wonderful. So because you have answered multiple questions in the chat box from Vamsi Krishna, who was asked on what are the pattern of CPET parameters in moderate to severe deconditioning, we have answered that. And Dr. Sunita V. Narayan from Kerala, what are the parameters associated with muscular deconditioning? So both those questions we have answered. And one very different question, at AIMS, have you seen any death?
No. So we have not seen any death. So we have been performing CPET for last around 12 years at our center because it was a little late, but we have not seen death. But what I'm trying to tell everybody is that whenever you are doing CPET, you have to have a resuscitation card with you. You have to have a trained personnel who can do CPR, who can identify a complication, who is able to read the ECG or ST elevation happening during the test. So that can be, so this is what our resident does it, or our technician has been trained to do it. So if you have a trained personnel, you will not have a death, but that means you may have to prematurely stop the test. So we have done premature stoppage of test because patient had something during the test, but we have not lost a patient to the test. So that means being very vigilant during the test is very important.
Yes. So that answers Dr. Ashwit from Tamil Nadu Vellore. And there is another question by Dr. Suman Rathod. What are the emergency equipment? Yes, both has been answered. Now we move on to the ventilatory parameters by Dr. Nitin. Sir, is always a low breathing reserve abnormal, or how do you decide if it is clinically significant, if the patient has not done the test well or has been deconditioned? So how do you differentiate it, whether it's significant or not?
I think if you look at the marathoner or a super duper athlete, then he is able to use the breathing reserve to the almost to the fullest, and then you will actually kind of, in that kind of situation, you will not call low breathing reserve abnormal. But in most of the disease conditions, it will be abnormal, and that the typical causes of low breathing reserve are either coming from a low FEV1, that means it's an obstructive disease, or it could come from a poor gas exchange. For example, if the patient is using physiological dead space ventilation, in ILDs also you might have a low breathing reserve. And of course, if the patient is breathing erratically, as Saurabh had just said, rapid shallow breathing, in that case also you will have low breathing reserves. The typical, if I have to look at other abnormal ventilatory responses, too much of an hyperventilation, a respiratory rate going beyond 55, or a blunted increase in the tidal volume in less than 2 times from the baseline, kind of things, or a VT upon inspiratory capacity ratio going beyond 85%. This typically will happen in restrictive lung diseases. So I think so on and so forth. And of course, the last but not the least, post-exercise bronchoconstriction. So I think all these we have to keep in mind when we are interpreting these.
Okay, wonderful. That has also answered the question from Tajmul Hussain from Kashmir. How do we know what are the parameters to see that the patient has given his best or dull efforts, that it is not a submaximal effort? Okay. Next, we move on to Dr. Balamugesh there are so many questions coming up. I'll keep clubbing the questions. In cardiac limitation, Dr. Balamugesh, so how do low peak VO2 and early anaerobic threshold reflect impaired cardiac output response to exercise?
So, maximum oxygen uptake is dependent on the cardiac output. So, the cardiac output is equals stroke volume multiplied by heart rate. So, when a patient has exercised maximally and achieved a maximal oxygen uptake, so that reflects the cardiac output indirectly. So cardiac output means it's a multiplication of stroke volume and heart rate. So whenever there is cardiac limitation, whether there is impairment of stroke volume or impairment of heart rate response, there is decrease in the peak oxygen uptake. Also, whenever there is cardiac limitation, there is inadequate augmentation of oxygen delivery to the periphery. And this causes early onset of tissue hypoxia, early lactic acid accumulation, and causes anaerobic metabolism to occur early. And this causes reduced anaerobic threshold, typically less than 40% of predicted value. And that reflects cardiac output, cardiac limitation to exercise.
A couple of more questions to you from Dr. Fayuza, Jammu and Kashmir, Srinagar. What is the difference between a CPET and treadmill?
CPET can use treadmill. So CPET can use 3 types of exercises to test the exercise capacity. One is cycle ergometry. Second is treadmill. And third is what is called arm cranker. People who cannot walk, if you need to test, we have to use that arm cranker, this thing. So generally, the maximum oxygen uptake is found in the treadmill because the whole body moves. The uptake values, oxygen uptake values obtained by cycle ergometry is around 10% less than the treadmill, and the arm cranker will be the least. So these are the different types of equipments which we can use.
Okay, one more question to you, sir, from Dr. Muthu Nageshwar from Tamil Nadu. We use Schiller in our hospital. We notice that even in some normal people, there is always a O2 flattening that is happening. Has anyone else faced similar issues?
We also faced, it could be, we have to you got to look at the graphs, the units of the graphs and how different it is. If your units are not proper, although the oxygen pulse increases, you may not find that increase when you simply look at the graph. So you may need to monitor, change the units in the y-axis to make sure that you are able to increase the slope. Or you look at the absolute numbers. You look through the whole reading and see whether the oxygen pulse values are keeping on increasing. And finally, foremost is you'll have to see the calibration, whether it is proper or not, because one of the frequent problems which occur is the oxygen cell or the carbon dioxide cell is not properly calibrated. You need to call the company and make sure that it is functioning well. And at the start of every test, you need to make sure that it is calibrated properly.
Or is it possible that Indians have a flattened pulse? I don't know if everybody else is, because Dr. Bani and myself, we were talking, this is in our center, this question is coming up. So we have noticed that it is a flattening. So we need to also collaborate with other centers and find out if this is a common phenomenon seen across. So at this point, there is another question from Kushi from Gujarat. For regular CPET, would you use a cycle ergo or a treadmill? I think it depends on the patient and the availability. And those are the two main reasons. Okay. Moving on, Dr. Arup, I'm going to have a lot of questions in vascular and also in anaerobic threshold. We are having a lot of questions. So, so how do you differentiate in CPET pulmonary vascular disease from a parenchymal disease?
So, this is very interesting question again. So, pulmonary vascular disease and ILD are actually clubbed together in CPET as a pattern. So, in CPET, we see the physiological pattern during exercise. We do not give the actual diagnosis. That depends on the many other factors like the clinical features, radiology, and lung function tests, etc. So, pulmonary vascular disease, ILD, cannot be differentiated on CPET itself because they give a similar pattern, but you can get a ventilatory or the ventilatory limitation if the patient is having ILD. Obstructive lung disease, you can differentiate from the pulmonary vascular disease because they will come with the typical flow volume loop, and CPET also gives you the maximum flow volume loop, the exercise flow volume loop, and the tidal flow volume loop. So if you see your flow volume loop is gradually shifting from the residual volume towards the total lung capacity, actually you're decreasing the inspiratory reserve volume, and these patients have a flow limitation or expiratory flow limitations that suggest patient have an obstructive ventilatory defect, and the patient will also have a ventilatory limitation, which is less than 15% of the breathing reserve will be left at the end of the exercise. So pulmonary vascular disease, ILD, you cannot differentiate. You have to do an HRCT. You have to do an HRCT for. Am I audible?
Yeah.
You have to do an HRCT for that. And pulmonary obstructive disease and pulmonary vascular disease, that can be differentiated from the CPET.
Okay. So I'm going to go on to questions on RER. There's a question from Vamsi Krishna, Mumbai, who says, should we ignore a study with an RER of less than 1.1 or go ahead with interpretation?
So definitely, what is RER first? RER is the VCO2 by the VO2. So normally it is 0.7, but as we exercise, it tends towards more than 1. And a test with an RER of more than 1.16 or more than 1.2 gives you that the patient has a sufficient effort during exercise. Now, the patient may not achieve RER, especially in case of ventilatory limitations. So RER is achieved when there is an anaerobic threshold. But if the patient is limited by ventilation, he may have a sufficient cardiac reserve at the end of exercise, and he has not achieved RER because his cardiac reserve is still good. So you have to see RER again in light of other parameters, like whether he has achieved the maximum heart rate or not, what is the breathing reserve at the end of exercise, what is the O2 pulse. So everything should be dealt together, not a single value together. So definitely RER more than 1.16, you have a good capacity, but less than 1, you have to see whether the patient is limited by ventilation or not.
Wonderful. In the same context, can you also explain on RCP, the respiratory compensation point, the AT2?
So there is two concept of VT1 and VT2. That means whenever you are exercising, you are actually using oxygen and you are producing carbon dioxide. This is aerobic. Then it becomes aerobic plus anaerobic. You start rising the lactate. Lactate is produced buffered by bicarbonate, and that produces increased amount of carbon dioxide. So the production of the lactate and increased amount of carbon dioxide production, that is being separated by a minute amount of time. So we actually measure the anaerobic threshold, the VT1. VT2, you can measure the respiratory compensation, where actually with the rise of the VCO2, your ventilation goes up. That is the second point. But this is not very much clinically relevant in the present scenario. So just VT1, the 80 is sufficient enough for your interpretation.
Okay. Now the next question, I move on to Dr. Sachin. So I'm going to start reading the questions from the panel, from the chat box. So there is a, one second. Okay. So there's a question from Dr. Maithili Mohan Tripathi from Uttar Pradesh. The peak VO2 is low, but RER is 1.15 and heart rate reaches maximum predicted value. So what is your interpretation of that?
Generally, see, when we do a CPET, there are certain parameters initially to see whether the effort is optimal or not. These are all the three parameters actually. So generally speaking, there would be some limitation, but if you have other parameters going 80% and beyond 80% of predicted workload, heart rate is being achieved, VO2 max is also in that range, then RER of 1.15 is good enough to label the report as you can interpret further. So generally speaking, sometimes you can have one parameter falling marginally short, but that does not discourage us that this report is not valid, because 2-3 parameters taken together, if they are satisfying, then it's a valid report and you can go ahead to interpret actually.
Okay. There's one question from Vishwesh from Thane. What are the essential data that should be included in a CPET report? How do you present a CPET graph graphically, the 9-plot panel? And what are the quality criteria for acceptable CPET? And how do you integrate CPET to clinical decision making? I think there are, and ethical consideration. There are 5 parts to that.
I think one full lecture can be given to those questions, but just in nutshell, I think we can take it later on the second bootcamp. But see, there are 9 graphs in CPET. To make it simple anyway, just he has asked, that's why I'm telling. So initially, the first composition is to see whether the report is valid or whether the effort is good or not. So there are, for this is for him, like panel number 238. Are 3 things which says that whether the report is valid or not, or you should interpret regarding your VO2 max, then your O2 versus heart rate and workload, and third is RER. So that is first thing. Second thing, as I told you, at this stage, we should keep it simple that there are 3 blocks we are looking. One is heart, one is ventilation, and one is maybe gas exchange. So it's like a phone number, what we say to our students in our center. 235 is cardiac, 147 is ventilatory, and 689 maybe gas exchange. So to make it simple, 237, 689 and 147. So 235, 147, 689. So this is the order of the thing. But I think that requires a full deliberation. It's not as simple as this. Yeah.
Okay. And are there any ethical considerations for CPET in research or clinical use?
See, it's a varies between the what research are you planning, because see, if it is CPET is part of a clinical protocol which we are doing day in and day out, I don't think anything unethical we are doing in that. And second thing is a consent thing. Obviously, a consent has to be taken, explaining the risk is to benefit ratio and alternatives also, because see, sometimes just to prove ILD we will not do CPET. HRCT is better. Sometimes to see other pathophysiology, we have other tests also, saline contrast echo and other things can be done. So obviously, if you should have alternative being explained also, if you're not explaining only pushing for CPET, then it can be something seen as unethical practice for some concern. But I don't think anything unethical or ethical concerns are there regarding regular usage of CPET in research work.
Okay. Dr. Saurabh, a lot of questions coming your way. Some of them are being repeated from your talk. I think these are people who have joined in a little late. Dr. Atif Patel. So I'll read the question so you can club them and deliver it. Dr. Atif Patel from Maharashtra was asking what are the main components of a CPET system. And then there is a question from another one asking what are the indications and contraindications. And third, three questions I'll ask you. Do different protocols change the interpretation? That question is from Binisha from Jammu and Kashmir.
Okay, so when we talk about the components of a CPET system, so one is the exercise equipment. It can be either three of the ones which sir has mentioned, whether it is a cycle ergometer, it can be a treadmill or an arm crank. Now the key here is when we do means for patients who have poor reserve, a cycle ergometer is generally considered safer because it allows patient to sit and exercise. For like a less disease population or for healthy individuals, a treadmill is good enough. Okay, generally, so this is the one component of it. Second component is the gas measuring things. So gas can be measured from a mouthpiece or from a mask. So that is the mask which I showed in my presentation is put on the patient's face, and through that there are multiple gas sampling lines connected. So that means those things are measured. What is coming out and going in is being measured during that breathing. So these are the two components. Then you have cardiac components in terms of that you have to apply the ECG leads on the chest. You have a saturation monitor. You have a blood pressure cuff attached to the patient. So this is the basic assembly of a exercise system. And there are softwares which would guide you that how do you connect the test. So that's the equipment which you need. Now the second question was indications and contraindications. So indications, I would say in pulmonology practice, the most important indication is evaluation of undiagnosed exercise intolerance or undiagnosed dyspnea, where you are not able to do that. That is one very important indication. Second indication in our practice is a pre-operative evaluation for a lung surgery. Okay, so these are the two key components. But for research settings, you can do research on a intervention like pre and then you intervene and then you do post. Okay, specifically for rehabilitation studies, for other therapeutic studies. For transplant, specifically for cardiac transplant, CPET is very good that it gives you an answer that how risky is the surgery. So this I have kind of brought that what are the common in the pulmonology practice indication. The contraindications are anything which makes exercise unsafe for the patient is a contraindication. So in general, stenotic lesions, ischemic heart disease which is unstable, a recent MI, hemoptysis. So these are the common contraindications in severe AS or left main artery disease. So where patient can have a symptom or ischemia during the test. So those are considered the contraindications for the test. Now, whether the different protocols would suggest that there would be findings which vary. Yes, so there are a lot of protocols which have been tested during the CPET. So protocols can be incremental protocol or steady work rate protocol. So there are some differences which will come in the output, but overall most machines which are commercially available will have different protocols. But what I would suggest that you choose one protocol for your center and follow your patients on the same protocol. So there are some differences which will come in the outputs, but one protocol which suits you best is probably good enough.
Okay. So that also answers the questions from Dr. Mandeep Uttarakhand on indication and specific contraindications. And one more who had a question on contraindications, Dr. I'm sorry, I'm going up and down. Dr. Mehul Tana from Mumbai. Okay. We now move on to the ventilatory limitation. Sir, Dr. Nitin, there are multiple questions coming up on clinically, how do you identify ventilatory limitation on CPET and influence the treatment planning and rehabilitation strategies?
I think identifying the ventilatory limitations essentially, you are looking at obstructive and restrictive as your two main disorders. in the obstructive component, it is the hyperinflation which decides everything. It's not the FEV one, it is the hyperinflation which decides the dyspnea, and the dyspnea comes early when there is a dynamic hyperinflation. That is one thing which is worth remembering. In the restrictive diseases, it is actually, say in an obstructive disease, as was already told, that the IC goes on reducing and the whole story moves towards the total lung capacity, and therefore the person becomes more and more dyspneic. In the restrictive diseases, typically interstitial lung diseases, you will see a rapid shallow kind of a breathing pattern, and that's how you sort of start wondering whether this is there. And of course, the total, the tidal volume will be more than 85% of the IC, because of a restricted kind of a scenario. So that's how you go on to this. The idea of doing the whole the rigmarole of this cardiopulmonary exercise testing is not diagnosing a condition, but giving direction as to where to go from there and what to do. For example, deciding a fitness or that, so on and so forth. I think a rehabilitation is again a very good way out of this. For example, somebody who has never walked for say last 20 years because of his obstructive disease, and you make him do a test which he undergoes 15 minutes test, you know that there is a different time kind of threshold that he can cross, and therefore he himself, as well as you both, doctor as well as the patient, self-realization as well as doctor realizing that yes, he can do much better. And I think these takes us towards giving him a little more challenging kind of a target for rehabilitation, whether it is upper body, lower body, all those things will be different. So I think that is where the rehabilitation part comes in. Then, of course, the other way also, you may find out that some people are becoming too toxic or too hypoxic too early, particularly say an interstitial lung disease, getting into an hypoxia of 50 and needing to go into the rehab within the hospital itself is not a right candidate for a rehab in the real world kind of a scenario. So I think both ways it can go. So I think I hope I have simplified it enough.
Answered, and this has also answered the question by Dr. R. Dilip from Tamil Nadu on can CPET be used only for assessment or also be objectively used to quantify the response to pulmonary rehab beyond symptom improvement. I think both you and Dr. Saurabh have answered that. Dr. Balamugesh, what is the best method to determine AT?
So AT, there is no single method by which say that you have to use this method and that is the gold standard method to determine AT. So we use a combination of methods. The most widely used is the V-slope method, where VO2 and VCO2 are plotted together. And when you see that at one point of time, there is an upslope in that graph, that suggests the anaerobic threshold. And usually we look at that and then we correlate with the other two or three graphs as well to make sure that you are at the correct point. So then you look at the ventilator equivalence graph. The ventilator equivalence graph, the anaerobic threshold corresponds to the point where there is increase in the ventilator equivalence of oxygen without corresponding increase in the ventilator equivalence of carbon dioxide. That means that V by VO2 tends to go up, but V by VCO2 has not yet started rising. So that is one point where we can look. We can also look at the graphs of VO2 and VCO2 where that crossover occurs, where that VCO2 increases more than or crosses over VO2. And finally, you can look at the ARIA, respiratory quotient or respiratory exchange ratio also, and see at which point there is a dramatic increase in the RER, which should be around that area of 1. So by these 3 or 4 graphs, we can mark the anaerobic threshold. Sometimes we don't take the machine value on by itself. We go to the machine, we change the pointer here and there, check the other graph whether it is corresponding, it is satisfying the other graphs as well. So we make these corrections and don't accept the machine given value directly.
Wonderful.
Do we always do a lactate? Is it a must, or can you avoid it? And or we don't do it mostly?
So what we do in clinical practice is we do the baseline ABG, and at the end of the test, so that will give us an idea how much the lactate has increased.
Yeah, but for AT we will not use it.
No, you will have to have continuous ABG monitoring or capillary blood.
That is not realistic.
Yeah, that is not realistic.
I have 2 more questions for you from Mihir Mehta from Gujarat. How does CPET differ from regular exercise stress testing?
So in CPET, you make the patient exercise to the maximum. So we don't go by metabolic equivalence or the patient has achieved target heart rate. So the protocol which is used for the treadmill test is different from the protocol used by the cardiopulmonary exercise testing, because we need to delineate all these parameters in detail. So here, till the patient says I'm unable to go, or there are some of the end of stop test parameters which Dr. Saurabh has said, till that occurs, we make the patient exercise.
Okay. I think we need to go really fast because there are so many questions lining up. Fine. 1 second. So there is one question. Patient stops from Debrata Das. Patient stops exercise early with severe dyspnea, but breathing reserve is around 40%. So what is your primary limitation?
So breathing reserve is present, but patient has stopped exercise. Then we'll have to say that the patient didn't stop because of ventilatory limitation. Lungs are good. Respiratory, ventilatory mechanics are good. Then we'll have to look at other causes, whether it is cardiac limitation, pulmonary vascular limitation, musculoskeletal causes, or deconditioning. So based on the other parameters, we'll have to look at the causes of stopping, what caused the exercise limitation for this patient.
Okay, so one more question I'll take. Binsha Beg from J&K. In patients with chronic diseases like COPD, how can CPET be used to accurately differentiate between ventilatory limitation, cardiac or peripheral muscle dysfunction as the primary cause, and which CPET variables are reliable? I think we have discussed that in detail with the various graphs and plots. I'll now move on to Dr. Arup. Very interesting question from Ritabrata Mitra from Kolkata. Any idea on neural control from CPET? I didn't get the question though.
So Ritabrata always asks difficult questions. Definitely would not measure anything neural control of ventilation during CPET. But we know that dyspnea is a neural mechanism. So you have a high respiratory drive, but that cannot be measured in CPET.
Okay, fine. Another question from Dinesh, Tamil Nadu. VO2 is plateauing out, but the workload is continuing. Is this true? Is this true VO2 max?
So VO2 is plateauing out, but the workload is increasing.
Workload is
increasing. The patient probably has, if the patient has reached more than 75 or 80% of the workload, then probably he's achieved the VO2 max. That's why the VO2 is plateauing. If the VO2 max is not plateauing, then it is called a VO2 peak. So I have hardly seen any patients in Indian patients where we have achieved the VO2 max and after that it is plateauing, because we are all using the European standard for calculation of our VO2 max.
Okay, fine. One more question I'll go on, sir. Low peak VO2, normal breathing reserve, low O2 pulse. I think they're all
low peak VO2
and normal breathing reserve and low O2 pulse. I think it's cardiac.
Oh, So low peak VO2, normal breathing reserve, low O2 pulse, maybe cardiac if the AT is achieved within 40%, but it may be inadequate effort also. Patient has not achieved adequate VO2, and the O2 pulse has not increased because he has not exercised that much, so that the stroke volume has increased, and the breathing reserve is normal. So you have to look at the AT in that person to say whether it's an inadequate effort or a cardiac limitation.
Dr. Sachin, so what are the commonly used protocols? And can you elaborate on a couple of protocols that we use?
Generally, that's what. So generally, it depends on the equipment you are familiar and you're using at your center.
Protocols on
Bruce protocol and all those things, they are pretty standard. So generally 10, in measures of 10, we increase the workload sequentially, and most of the time it is at our center and other centers also. Ergometer and all those things are the most common protocol, but generally other protocols are very rarely used. So generally most common is Bruce.
So there is a modified Bruce protocol which most of us use, but there is also a Wingate protocol for athletes, and then in those who are using Schiller, if we can't use a Wingate, we push the patient into anaerobic threshold, and then from there 10 seconds how the patient is able to perform. So sometimes we tweak it and then try to get what is the answer that you are basically looking in for. Okay. Sir, can you also elaborate? This was a question from Atif Patil from Maharashtra. Next is from Vamsi Krishna, Maharashtra. How important is heart rate recovery? Any variation with the type of device used?
So question is to me for ventilatory thing, the heart rate reserve. So basically see, generally as you talk about breathing reserve is for ventilatory limitation, heart rate reserve for cardiac thing. So generally speaking, again, 80% if somebody has observed, then it's not like a cardiac limitation to the disease. So generally speaking, heart rate reserve, generally if you have exhausted all at a lesser workload, then it points to a significant cardiac abnormality. Then you have to see the other VE upon VCO2 and end-tidal carbon dioxide to see whether there is an additional component of pulmonary hypertension or vasculature being involved. So those things can be looked into, but roughly heart rate reserve corresponds to how much you have exhausted your cardiac reserves as per the workload.
Okay. So the next question by
Dr. Supraja, may I add one thing? So it is very important to look at the recovery periods also, because in the recovery period, if you have a heart rate recovery of less than 12 beats per minute, so that suggests the patient may have a cardiac problem, and patient should be actually evaluated by a cardiologist. So that is very important, the recovery period, the heart rate recovery. It should be more than 12 beats per minute for a normal person. Second, you have to look at the anaerobic threshold or the RER also in the recovery period. Sometimes it may cross 1.3. That may not be present in the maximum exercise. So that again suggests patient has a cardiac issue. So these small informations are very important for a report interpretation.
Okay. So before we move on to Saurabh, I think that I want to recognize people, Binisha Beg and from JNK and Shabri, both of you have asked the same question on how to differentiate the various parameters. We have discussed that. And Dr. Jikisha from Maharashtra on patient safety, we have discussed that again. And Ajay Kotia from Gujarat, physiological parameters, we have discussed. Dilip Kumar from Tamil Nadu, I think I'll pass this on to Saurabh. In patients where AT cannot be clearly identified, how should we interpret exercise limitation and what does that indicate physiologically?
Okay, so there are two situations. If you cannot identify AT1, the patient has actually not reached the AT. Okay, so patient has a very bad limitation, whether it is cardiac, whether it is peripheral muscle. So patient stop exercises before even reaching the AT. So you'll have the two curves which are going separately and they never meet. That is one point. Second point is that you are not able to exactly point out where the AT point has reached. If you are having a difficulty on your machine, that how do you identify? Still, you should look at the data. So the key thing which I have been telling from the beginning is that CPET interpretation is not one parameter. So it's an integrative approach of all these parameters. And if your clinical suspicion fits into what you have found, then you should interpret the test rather than discarding the test. So there are various reasons patient may not have been able to reach AT, whether they have dysfunctional breathing, whether ventilatory limitation, but still you should look at other parameters. If any of them qualifies as a maximal test, then you should kind of interpret it.
Okay, in the same context, there's a question from Pooja. on your exercise limitation, can inflammation be identified? Something like C-reactive protein or inflammatory markers, their impact on the muscle dysfunction, can it be identified?
I'm not sure of it, so sorry.
Okay. There's one question from Dr. Anybody else for the question? I don't.
Inflammatory markers. So maybe
Yeah,
inflammation.
We cannot measure.
We can't measure. Yeah. So Dr. Krishnaveni from Tamil Nadu. So given the variability in peak VO2 between Indian and Western cohorts, should CPET software include India-specific predictive equations? And if yes, should ICS lead a multi-center reference value? I think I'll ask this to Saurabh and Dr. Balamugesh. Yeah.
Okay, so obviously most machines use, but I think Balamugesh sir has published a paper long back on the normal values. But of course, we are going to have a lot of differences in regional and their lifestyle based differences. So I think I won't say ICS, but I think there's global work which is going on. Like you have got now GLI for the PFT, so there's work going on for GLI for the CPET also. So that would probably, so they have asked. I think they have taken data from the papers. I think one paper is from St. John's, one is from Dr. Balamugesh. So that work is already under process from the global efforts. But yes, it will be good if a lot of centers can collaborate. The only problem I would tell, because I also tried to do this study, but I could not, is to take people on board, and making healthy people do CPET is generally a very challenging. And if you get the hospital staff to do it, that means it's not a community representation of the thing. So there's a lot of bias when happens when you look at the normal data of community individuals.
Dr. Bala?
Yeah, so it's the need of the hour, but it has its own challenges, as Dr. Saurabh has told. Also, the type of equipment which we use, the standardization of the protocol. So all these are the other things which will have a challenge in having a multi-center study to establish normograms for Indians, but it should be done.
Our Pune has a big enthusiastic group which goes to Everest base camps and Leh Ladakh every year. So we encourage some of these people, and they come for their VO2 max before they go, and after they have done it, sometimes they do come back and do it again. So I think that can help in establishing the normal values for our people. If you do it all across the country, that might be again a good idea. This is of course for the normal people, not for disease people.
And that is a part 2 series which is coming on in special situation, in different situations, with Dr. Manoj Chopra joining from AFMC for the next session. Sir, Nitin sir, so there's a question from Vamsi Krishna in Maharashtra. Doing a 6-minute, is it equivalent with a steady load? So though we say that 6-minute walk test is the equivalent for CPET, but can you, in a steady pace, is it equivalent?
Generally, I mean, the lowest they have said is about 8 minutes, but 8 to 15 minutes is what it takes to, reach that. So I think the idea is the person should have reached those either of the two parameters, a VO2 max of more than 85 or a cardiac or a peak load of more than 80%, either of the two. So if he has reached both, better. And then the minutes don't matter. As we say, if we can't go on nitpicking, say 7.5 minutes, is that perfect? I mean, there is no right to that kind of argument.
I think that question more holds on for patients rather than normal segment. Also, can you also answer on, can CPET help in pre-operative risk assessment? I think we have discussed, but a few words on that, sir.
I think it would mean a great deal of thing, particularly if you find somebody who's desaturating too early, or is just not able to perform properly, and is expected to have a prolonged recovery post-operatively. Particularly for transplant surgeries, this is a very good pre-operative evaluation. Very important, must be done for all.
And even for lung surgeries, it is very useful as well.
Absolutely.
To add on, I think there is no other test like VO2 max which says that above 14 you go on medical management for cardiac transplant, less than 14 you go for cardiac transplant. So all tests together, only VO2 max makes the decision. It's like a
Single decision, single
yeah,
test.
to
Decides.
rule in and rule out of cardiac transplant in that scenario.
Absolutely.
So just yesterday, the European Respiratory Society and ESTS, European Society of Thoracic Surgery, published their updated guidelines on lung assessment, patient assessment before lung resection, curative intent lung treatment, which includes lung resection surgery, in which they have clearly mentioned the current role of CPET in assessment for lung resection surgery, and they have given the importance of the peak oxygen uptake as well as the VE by VCO2 slope. Not for everybody, but in selected subset, it is good for all of you to, all the delegates, to go through the latest ERS guidelines just published yesterday on guidelines for curative lung procedures.
Intent to treat.
So if the VO2, if the peak VO2 is more than 20 ml per kg per minute, this is going to be a very safe surgery from the physiological point of view. So that is a single number that is very important for us.
Less than 10 goes for palliative care and or ICU post-op. So it's a very good information.
Yes. So we receive a lot of cases for CPET from our Adyar Cancer Institute because they are high-risk patients undergoing surgery. So for them, for that segment, we are getting patients. So yes, we agree with that. The next questions, couple of questions we have already answered. Mehak, Mumbai, what are the acceptable criteria? We have done. Atif from Mumbai, what is CPET indicated in clinical practice? When is it indicated? I think we have discussed that. I'll move on to question to Dr. Balamugesh on OEUS parameters and how insightful it is. Oxygen uptake. Yeah.
So usually with exercise, the oxygen uptake also linearly increases. So the OEUS stands for oxygen extraction utilization slope. So this slope is used because it can be used even before the anaerobic threshold. Even if the patient has not achieved anaerobic threshold, you can look at the graph. And usually it is along with the oxygen uptake, the work rate also linearly increases. It is about 10 to 11 ml per minute per watt that the slope increases. But in those with cardiac limitation, especially, the work rate increases, but the oxygen uptake extraction doesn't increase as well. So there is some flattening. It is almost equivalent to the oxygen pulse. So this integrates the oxygen output response, the peripheral oxygen extraction, as well as the gas efficiency. And a reduced slope suggests that there is impaired oxygen delivery or oxygen utilization.
So a couple of questions on VE by VCO2 from one Mr. Murugesh in Tamil Nadu. The slope is high, but spirometry is normal. So what is your interpretation?
So the question is the VE by VCO2 is high, but
spirometry
the spirometry is normal. So that suggests that it could be due to the vascular cause. So patients with pulmonary hypertension, the spirometry may be normal, but the slope may be high, or it could be an early interstitial lung disease where it has still not affected the spirometry. Typically, patients with the combined pulmonary fibrosis and emphysema, they may have falsely normal spirometry, but still the CPET will pick it up and there will be high ventilatory equivalence for carbon dioxide.
Similar question from Shaibas from Maharashtra. Slope is normal, but PET CO2 is low. How?
Slope is normal, but PET CO2 is low. So I'm thinking whether it could suggest hyperventilation, where there will be washing out of CO2. But typically in hyperventilation, even the slope can be increased. Even at baseline, it can be increased.
Yeah. Sure, sir. And a couple of questions where I would like to acknowledge people in terms of, one second. I'm sorry, I'm losing track back and forth. Maybe I think I'll move on to the next question to Dr. Arup from Sabarikandan. When should CPET be terminated early? I know we have discussed, but a couple of words on that, sir.
Okay, so if the patient is symptomatic, either accompanying of chest pain, dyspnea, or a patient having a leg fatigue, then this is the indication that we have to stop the test. Or if there is a sudden hypotension, so that is an absolute indication of stoppage of a CPET at that moment. Or if the patient is having any arrhythmias or any significant STT changes, definitely these are the signs where we have to stop the CPET.
Sure. I think the same question has been asked by Debashish Paul from Bengal. We acknowledge that. And then there's one question from Sundareshwaran from Assam. How do you ensure patient safety during CPET? I think we have discussed that. Debashish Paul, how is it used in transplant evaluation? I think we have discussed that. One more question to you, sir. Arup sir, from Santan Kumar from AP. V by VCO2 slope is 45 with normal PaCO2 at rest. What is
normal PaCO2 at rest, but VCO2 is elevated. So it may be multiple causes. VCO2 raised means it may be a pulmonary vascular disease, it may be a cardiac disease, it may be a lung disease also. You have to look at the other parameters, what is the AT, what is the O2 pulse, what is the breathing reserve, and based on the combination, you can arrive at a diagnosis. Not a single parameter or two parameter will give you a diagnosis. If the VCO2 is 45 and PaCO2 is low, then you can say that this patient has a pulmonary vascular limitation. But normal PaCO2 will not give you any other diagnosis.
Okay, couple of questions I would like to acknowledge. Gajendra, can it diagnose peripheral muscle disorder? Yes, we can do. Sabari, okay, not Sabari. Ajay Kolkata, severe dyspnea with normal peak VO2. I think I'll give that question to Dr. Sachin. This severe dyspnea with a normal peak VO2.
See, then again, there are many parameters which possibilities which can do that. And first of all, we have to see whether it's a pathological thing or not, because if patient is deconditioned or any anxiety also will have this pattern that patient is having good VO2 max, but he is experiencing dyspnea. Second thing is that generally in our case, again, this VO2 max should be coupled with other parameters like exercise-induced desaturation or alveolar arterial gradient. These two are more sensitive marker because other parameters even are normal initially, but early picking by it's like a stress test. Suppose person desaturates, so this could be the early first marker for an ILD or even the pulmonary hypertension which has gone undetected, which initially if mild degrees they can have VO2 max, but then these parameters will reflect. So only with high preserved VO2 max with dyspnea sensation, one is to rule out extra cardiac, extra pulmonary thing first, and then maybe zero down to other parameters and see whether we are dealing with some other mild diseases which can be unmasked with exercise induced desaturation or other parameters like alveolar arterial gradient.
Super. So we are at 10:15. I have 6 more questions left. If nothing more is added, I would like to start with Saurabh. There's a question from Vamsi from Maharashtra. Is it mandatory for VO2 and VCO2 to cross over?
So yes, so if patient has a good exercise, I mean, patient has done the test properly, they will cross over because eventually the aerobic respiration will switch over to anaerobiosis. So it may be early in diseased, it may be late in healthy, it may be very late in athletes, but it will happen.
Okay. Next question from Narsingha Rao from AP. Taking too long for the heart rate recovery, does that indicate a heart disease?
Yes, yes. So if heart rate recovery is slow, it does tell you there is a problem, whether it's autonomic dysfunction, whether it is cardiac. So that means that needs a further evaluation by a cardiologist for cardiac dysfunction.
What about medication impact?
So if patient is on beta blocker, that will create a problem because, I mean, we have not really talked about the chronotropism too much, but if you have a problem where you see that heart rate is not increasing and it is ceiling at very low, maybe 90, 100. So there might be some variable heart blocks which are happening and which is leading to. So that chronotropic problems can also be leading to the exercise limitation.
Also, does it affect the recovery medications?
Not for recovery, not for recovery.
So yeah. Okay. So the next question is from Dr. Jyoti, Delhi. For bicycle, what should be the protocol? As in treadmill, we generally use modified Bruce.
Yes, so bicycle, you can use the constant workflow protocol, or you can have a serial escalation. So different devices will have different protocols. I think the key which I would like to mention here is that the protocol should mention how much watt increases per minute. That is very important. So some people will do exercise test at a watt of 15 or 20. That means every minute 15 or 20 watt would increase. So if you are doing CPET for your disease population, specifically patients who have a kind of severe degree of disease, then your protocol should mention a watt of 5 to 10. If you are doing for healthy or athlete, you can go to 20-25 watt per minute. So that is very important, because if you put a, supposedly if you put a 15 watt per minute work rate increase for a disease COPD individuals, he will stop exercise in 2 minutes. So that means we have to have a protocol which allows the patient to exercise for 7 to 8 minutes at least, to have all good physiological responses. So that's important, that what value you choose for your test.
Next question, I will move on to Dr. Arup. This is a very different question. Dr. Sunita Narayan from Kerala. How will interpretation of CPET differ in patients with hemoglobinopathies and people living in high altitude?
That's a very interesting question. So in CPET, that is the parameter is based on the fixed principle, the fixed equation, where we have the VO2 is equals to the stroke volume. Stroke volume is equal to the heart rate into cardiac output into the CaO2. That means the oxygen content in the artery minus the venous. So definitely, if the hemoglobinopathy is there, the oxygen content is going to be low, and the VO2 will be falsely low. And in high altitude, the oxygen content is high, the VO2 may be falsely high. So there is a provision for correction for the hemoglobin level, but that we do not do routinely in our practice. But that should be kept in mind.
Yes. Dr. Bala, Vamsi Krishna from Maharashtra, he's asking, long COVID, is it considered as neuro deconditioning? I think, so being the center which has done the maximum number of CPET in the country, I think post-COVID, how was the experience, sir?
So unfortunately, during COVID, we shut down all our CPET services because
Mask and
it is more intensive, because you are using the problem with the sensor, the mask and everything. Because of the issues with it, we stopped doing it. So, so long COVID, there are many studies which have specifically done in long COVID individuals with the cardiopulmonary exercise testing. And people have come up with various phenomena. This thing. One of them is the muscle. One of them is deconditioning. One of them, the the muscle injury, myositis due to the COVID. So they suggest that there is continued inflammatory markers after the COVID recovery, which continue to cause some muscle inflammation, and which is limitation, which causes limitation to exercise. So there are studies which have been done for that. So so it is an interesting proposition. So any patients with an unexplained dyspnea, we should do CPET. Any people with disproportionate dyspnea. So if the patient has COVID and has the lung fibrosis, that itself can explain. But normal lung function, but still they are dyspneic, we should think about CPET, and then which could pick up this deconditioning, muscle inflammation. It can also pick up a dysautonomia, inappropriate heart rate recovery, heart rate response, and it can pick up some patients. One of the manifestations is a neurocognitive manifestation. So even anxiety, hyperventilation, dysfunctional breathing can be picked up by the cardiopulmonary exercise testing.
yeah.
Just to add on one caveat in this, that we have seen many exercise-induced desaturation also one parameter in long COVID, because they come with dyspnea, PFT is normal, everything is okay, DLCO is mildly decreased, but on CPET, they have a significant desaturation, maybe because of microthrombi and microinflammation and all those things, vascular involvement.
Okay. Just I was thinking of winding up the sessions. There are 5 more questions which are lined up, but anyways, we will at least come to a logical closure. I would like to ask Dr. Nitin, sir, after doing a CPET, so clinically in a pulmonary patient, what would be your, how would your treatment plan be for that patient? Now, PFT is normal, CPET is having a ventilator limitation. How are you going to proceed for management in these patients?
Yeah, I think lung function being completely normal is unlikely, but at the same time,
Repeat
if it
PFT.
is, if it is in the truest sense, then I'll move on towards some other newer technologies like impulse oscillometry and pick up whether there's a very subtle obstruction which I'm missing and treat it accordingly. So I think if I have found something new on this, then I will go into that direction. For example, if I think there is something wrong with the pulmonary vasculature, I'll go with a CT pulmonary angiogram and then treat that component accordingly. If I find a pulmonary arterial hypertension, I'll be going and treating that part. So it depends on what I find, and this is not going to be the only diagnostic test which I will use for deciding everything. I think this is a pathway towards exploring it further rather than just the final answer. This is not a panacea to everything. That is what I will keep in my mind.
Thank you, sir. Dr. Bala, in your day-to-day practice, how are these decisions going to alter cardiac referral for or further cardiac testing with respect to cardiac parameters and abnormalities?
So many times the resting ECG echocardiogram is normal, and then the patient comes to us to evaluate for respiratory cause of breathlessness. And when we do the basic lung function, everything, we find that it is normal. Then we think of doing CPET. So the CPET comes into play, and it shows that during resting parameters normal, but when the patient is stressed, the cardiac output is unable to meet the metabolic demands. And then there has been instances when we picked up chronotopic incompetence, and we referred them back to the cardiologist saying that sometimes they may need to do tests like a stress echocardiogram to find out exercise-induced ischemia and LV dysfunction. So we come across situations in which resting parameters are normal, but CPET has found out that there is probably a cardiac limitation, and we made appropriate referral to cardiologists to have a relook.
Okay. Dr. Arup, the similar lines, CPET in pulmonary vascular, or pulmonary hypertension. So how are you going to address it before resting hemodynamic abnormalities appear? Will we be able to pick it up and then give a solution to the patients?
So in pulmonary vascular disease, when a patient comes to us with unexplained dyspnea and we get the lung function test cannot actually differentiate between the obstruction or restriction, but having a very low DLC, that gives you an initial suspicion this patient may have a pulmonary vascular disease. Then if you do a CPET in these patients, they will give you the characteristic abnormality of a pulmonary vascular limitation. So that actually gives you further evidence to support your diagnosis. But again, that is not confirmatory. You have to do a right heart cath. And you can do also exercise-induced pulmonary hypertension measurement with a exercise, doing a right heart cath exactly during the exercise, but seldom that is done nowadays. In some Western countries, it is done definitely, but nobody in India does it. So that is a matter of theory, but it will give you this pattern, which will give you a confidence in diagnosing this pulmonary vascular disorder.
I think, but there are certain cardiac centers, very few cardiac centers which do right heart cath and further evaluate. And Dr. Sachin, I'm going to ask you a question on how does CPET differentiate between diffusion limitation from ventilation perfusion mismatch?
Yeah, so it's a very interesting thing. See, how to understand that is when we breathe, some amount of blood will be there in capillary for some time, roughly three quarters of a second, 0.75 second is the time where the blood is there. And it takes only 0.25 seconds for the oxygen to reach equilibrium. Now, whenever you have a diffusion limitation, suppose there is a thickening or parenchymal destruction in emphysema, then two things happen, where the equilibrium will take longer, and when we are doing exercise, the transit time is less because the available time is less. So these two things taken into the picture. So diffusion limitation versus VQ. So normally, if you exercise, if there is a sudden drop in oxygenation and precipitous, because they would be normal at initially, but if you start to do, and there will be early desaturation. So initial 1 or 2 minutes they will desaturate, and they will desaturate very fast to 80. So most likely it is a diffusion limitation, and it is mostly because of ILD. Versus VQ mismatch, V upon VCO2 as the main parameter is there, it will be very high, and E2CO2 would be low. So that is mostly for the vascular cause of it. And second thing is ventilatory reserve or respiratory reserve. If you exhaust, then again it is ILD because of other parameters. Third thing is response to oxygen also, because many times or most of the time the diffusion limitation patients will again become normal on supplementation of oxygen. But in case of VQ, especially if shunting is there would be very less response to oxygen. And thirdly is generally the dead space ventilation, VD by VT, what we say, and the surrogate marker for V upon VCO2 and end tidal carbon dioxide. Again, it will be more in VQ mismatch. So the VD upon VT ratio, normally as you exercise, it should fall. But if it is not falling, it is increasing, then it is V by Q mismatch. So generally speaking, two parameters are very important. One is that precipitous fall in oxygenation, then VD by VT ratio. And also if you exercise, keep on exercising, the alveolar arterial gradient, what I was telling you, it will keep on increasing in diffusion. But in VQ mismatch, it will increase but stabilize. It won't keep on increasing. The widening might not be very much, but in diffusion limitation, the widening is very high. So these are the subtle things. Obviously, better is or easier method is to see the DLCO.
So coming on to Saurabh, in the context of non-cardiopulmonary limitations, how are you going to use this CPET to guide your non-pharmacological interventions, such as exercise prescription or a breathing retraining or lifestyle modification?
So I think as a pulmonologist, we see a lot of this obesity and deconditioning patients who come to us for evaluation of dyspnea, and CPET has helped us a lot in deciding our treatment plan. So whenever we don't see peripheral muscle dysfunction that much, but deconditioning and obesity related is very common. So once we find out the cause, we can focus on the patient's exercise training program. So when we prescribe rehabilitation or weight reduction therapies for exercise for weight reduction therapies, we generally look at the VO2 max, and then gradual increase in that can be given. So when we have machines which will give us what is the maximum watt patient achieved during the test, so we can give like maybe 40% of that patient can start with, and gradually it can be built upon when patient kind of gets used to or gets conditioned to the thing. So it helps in the deciding the workload during the rehabilitation program. It helps us guiding and motivating the patient that, okay, this is your cause of your dyspnea. That means you need to go towards your improvement of your diet, or you need to go towards the muscle strengthening exercise that will improve your symptoms. So CPET actually, there are patients who are running around that they have dyspnea, but nobody is able to diagnose them. And generally they are deconditioned. So CPET actually tells them the correct answer and helps them go in the right direction. At least in our practice, we see it very often.
Okay, wonderful. So you've answered everything, and also the question by Dr. Jyoti from Delhi. Also, do we need to go for 5 to 10 increment or a higher one in these patients? Just on that alone, you answer.
So once you have a patient who comes with dyspnea, I would generally say that you keep 10 to 15. Don't go beyond 15 for the incremental walk, because you need a time for the exercise to happen. If patient stops exercise at 3 minutes or 4 minutes, then your all exercise responses would be lost. So you keep it lower for like dyspneic patients, and you keep it high for very fit patients.
One last question, Saurabh. I'm sorry, one from Vamsi Krishna, Maharashtra. If ramp is low, the duration to achieve predicted load, does it increase?
Yes. Yes, so if you have a supposedly you have a fit individuals who comes to you like Dr. Nitin mentioned, athlete, and you start on 5, then they will continue to exercise for 20-25 minutes. Okay, so that means your load selection should be there. Otherwise, you will not be able. The ideal time of exercise should be 8 to 12 minutes. The patient should be able to exercise for 8 to 12 minutes. So that's how you would select your load.
So I think we are at the end of 2 hours of an incredible discussion on the basics, and basics sounded extremely, well versed, and people have come in with amazing questions. I would like to wrap up by thanking ICS for giving this wonderful opportunity, Dr. Rakesh Chawla and Dr. Amita Nine, and partners Schiller and Cipla. I would like to thank my speaker, the wonderful dynamic speaker, Dr. Saurabh Mittal, the youngest in the group, for giving a wonderful initiation and then the end, and the beautiful panelists from Northeast, West, and South, Dr. Nitin, Dr. Balamugesh, Dr. Arup, and Dr. Sachin. Thank you all for joining us and giving us this wonderful lecture series, and hope to meet you all on another day for the special situation. I think in this context, we should probably look at a workshop with the number of questions that are getting bombarded to us on the interpretation. I think maybe we can look at a online webinar or a workshop course that can be conducted for people those who are interested. Yeah, fine. Thank you all. Thank you so much.
Bye bye.
Cipla,
Thank you, Supraja.
Thanks a
Thank
lot.
you,
the
everyone.
last words, please. Yeah.